Well, I'm Dr. Jim Rosso from Las Vegas, Nevada, here with part 2 of Tea with Dr. D with Dr. Lauren Lam from Calgary in Alberta, Canada. And had a great part 1 episode of our first video podcast under Derms and Conditions, the Tea with Dr. D series. And Lauren Lam was kind enough to impart her knowledge and how she approaches hidradenitis suppurativa. In part 1, went through a lot of details. I don't think that's the only disease she sees in practice, but she sees a lot of patients with hidradenitis suppurativa. But in part 2, I've heard a lot about deroofing. We talk a lot about deroofing, and I'm wondering how many dermatologists know how to do deroofing or even how to integrate it into their practice, especially a busy practice, or when it's indicated. You know, how do you select a deroofing procedure? So Dr. Lam is kind enough to put some information together and some graphics together. So we're going to walk through this, right, Lauren?
Absolutely.
We're going to walk through this, right?
Yes.
So she's been in practice, in private practice in Calgary for 5 years. God, I wasn't anywhere near this advanced when I was 5 years out as she's become in this area. It's a lot of work, and I tip my hat to you on that. But let's talk about how you identify a patient that deroofing is indicated, because you said in the first part that patients may hear about it, they may see about it in the video. You might be telling them that's not something we need to do right now. If we get to that, we'll tell you more about it. I just want you to know that there's a lot of options that we can utilize to get you better. So you don't want to give up, right? But now you're at the point where you're deciding that a patient needs deroofing. How do you determine that?
So deroofing should really be done for scarring, sinus tract scarring, or if you have an acute flare, an abscess, you can also deroof that as well. So those would be the types of lesions that would be most ideal to deroof. If someone's a stage 1 with no scarring, it's better to inject with steroids.
You're talking Hurley stage 1.
Exactly.
Right. But can I stop you for a second?
Yeah.
They might look like it from the surface.
Yes.
But do you ever have times when you palpate
Yes.
and you say, oh, there's something going on there?
Yes.
Right?
Every patient, when I see them initially, I always do palpation in the area, because you'd be surprised. They look like a Hurley stage 1, and actually you feel the ropiness of the sinus tract underneath, and then you realize actually you do need deroofing.
Or they have a double comedone, which is a superficial sinus tract, right? I listened.
Exactly.
I listened. I heard every word, right?
Hats off to you.
So now they're upstaged to a Hurley too, just
Yes.
because of the double comedone.
Exactly.
Right? Okay.
I think the other flip side for decision making for the dermatologist is, are they medically managed well, and are they still flaring despite that? So do they still have 1 or 2 persistent areas despite being on a biologic? Those are perfect lesions to deroof. Has this lesion been injected twice? That's another quota that
Corticosteroid injection, so they've been through that
Exactly.
twice. Right.
Exactly. If a lesion's persistent, even despite that, then I'll deroof as well.
So I'm envisioning that you have a patient, they have hidradenitis suppurativa, they have lesions, nodules, abscesses, maybe some, sinus tracts, and you get them on a biologic and so much of it improves, but they have some areas that were pre-existing that persist. You can deroof those lesions even while they're on the biologic?
It's better to do it and not to stop the biologic. There are studies like the SHARP study that's looked at deroofing plus being on a biologic, in that case adalimumab, and it is safe to do with both. And in fact, if you stop the biologic, you're going to get flaring again. I like to tell patients that deroofing is like fixing a cavity. You need to still be brushing your teeth so that we don't get new cavities forming, right? So in the same way, we need medical management to be on board so that we actually get ahead of it and we can get to clear, as opposed to, I clear this one, but now you got a new one.
Right. So, Lauren, I don't know about in Canada, but we brush and we floss. I just wanted you to know that. Just wanted, and looking at your teeth, how good they look, I have a funny feeling you do the same thing, right? So,
Having said
yeah.
that, I do have patients that are hesitant to be on biologics, or maybe they just have one single lesion on the entire body. I will deroof those as well, but I always let the patient know that this doesn't mean that you might not get a new one. So if you get a new one, we might have to think about medical management.
So deroofing sounds scary, doesn't it? It sounds like a hurricane and the whole roof of your house got blown off or something. A bad storm. But
Yeah.
so now you how many lesions are you deroofing at one time, right?
So if you're first starting out, I would highly suggest just doing one small one at a time and booking probably 45 minutes for yourself just so that you have the time in case it becomes more extensive. Nowadays, because I've been doing it every week, all day on Fridays for the last 4 or 5 years, I could probably do 3 or 4 areas of multiple small lesions, or for example, an entire axilla in half an hour.
Right.
But that's been
So
lots of reps.
these are obviously scheduled. So
Yes.
you can, I would imagine sometimes you have an idea this is going to be a bigger one. You're palpating or the lesion even visibly has size to it. But other times you get in there and it's like, whoa,
Yep.
this
It's
is
definitely happened.
there's a lot more going on here. It's obviously going to take you longer. So, from a practical standpoint, do you give yourself a little cushion of time in the scheduling, or you just deal with it as it comes?
I So I have two nurses that work with me, so I actually do it back to back all day. So some lesions are going to be really small and take less than honestly 3 minutes for me to do. And then some lesions might surprise me, but you've caught up. So sometimes there's a bit of a balance. And I find that's also a really important thing. We'll talk about consent later, but definitely needs to be consented that sometimes you can get a way larger lesion than
Right.
anticipated.
Yeah, I remember, seeing on forms if you're going to have laparoscopic knee
Yeah,
surgery or something like that, they tell you that, hey, something could happen that we are going to have to do an open surgery at the
absolutely.
time. So you're
Yeah,
consenting to that, even though that's not what's anticipated,
of
right?
course. Yeah.
So supplies and equipment, which
Yes.
we're going to show a
Yeah.
tray and go through what you need to make sure is available. So can you succinctly go through that for us about the
Yep.
equipment?
It's actually very simple. So you need a curved pair of scissors, forceps, and a curette. And then you can use Moncel solution for simple lesions for hemostasis. And that's really about it. The other important tool to have is another set of hands. Just given the areas that you're working with, you really need the help with retraction sometimes.
And with Moncel solution, do you ever get that iron
Tattooing.
staining, that discoloration?
You can definitely get that. So you can use aluminum chloride instead, for example. But interestingly, I've found that because I use intralesional tranexamic acid, uh, I also use it now for when people get that tattooing just to lighten up the tattoo a bit.
So gauze, I'm sure you need nonstick Telfa type dressing or non-adherent dressings in the areas so it doesn't pull the skin.
Absolutely.
And what about the home care? What's the post-operative course? I would imagine the lesion size will dictate how long it takes to heal, but on the average, and what do they need to do at home in their post-operative care?
Absolutely. So for lesions that are about 2 to 4 centimeters, I tend to quote about 3 to 4 weeks of daily dressings. Depending on if you're using things like a nanotechnology wound care gel, for example, or if you're just using some sort of or topical antibiotic or aquaphor, for example, for wound healing, the quotes can actually decrease by 30 to 50% if you're using some of these wound care gels.
Unless there's evidence that a topical antibiotic's preventing infection, I tend to stay away from those, especially bacitracin and neomycin, because they call you and tell you it's infected.
Of
But,
course.
oh, it's itching a lot. It's a
Yeah.
contact dermatitis,
Yeah.
right? So I like the idea of the non-antibiotic. So you're not really concerned about the topical antibiotic stopping infection. There's
It's
not a
not so much
rampant.
infection, but it's biofilm that forms
I
a
see.
lot of the time
Oh, wow.
because you're
That's
working in
interesting.
folds, right? And these
Right.
become almost like chronic wounds. And we know that the biofilm is already altered in HS, so that's definitely the most common complication patients get.
And biofilms like to protect the organisms
Yep,
from us and anything else we're going to do. So what about the
exactly.
preoperative consultation? Can you walk us through the preoperative consultation? So you're going to de-roof me, okay? I've signed the consent. I'm
Okay.
like I'm scared.
Yep.
What is
Yep.
this lady going to do? but let's go through the consultation.
Right. So again, this has been totally practice changing for me. I have a video which we will make available. There's a YouTube version that you can play for your patients. It's meant for anyone's clinic. So it goes over what is HS very briefly, why does deroofing help in HS, and what to expect in terms of the actual procedure itself and excuse me, wound care. So the procedure itself, it's usually about 30, 45 minutes done with local anesthetic in the clinic. And by the time they go home, they're going to be using essentially Mepor or like gauze type dressings. So I find that by playing the video in the room, I actually don't need to explain what a deroofing is many, many times a day. I have a handout that goes along with the consultation that has a QR code that you can rewatch the video. It goes over everything that we talked about in the consultation itself, about step by step what we're doing. And really the only thing that I need to tailor to the patient in the consult itself is how large the wound is going to be and how long to expect for dressings.
So you show them in the video varying sizes of the lesions, and
Yep,
then you can surmise with a
exactly.
range of
Exactly.
accuracy or whatever,
Exactly.
how long it's going to take, right?
Exactly.
So you're
I also
saying,
have a prescription for numbing cream at the bottom of my handout, and that way the patient can fill it before they come, and that has also been practice changing. I don't know that Dr. Chris Keeling was the one, he's a dermatologist who trained me how to do deroofing. I guess maybe they just hadn't thought to do it, so I never thought to do it until the last few years, but these lesions are so tender, they need any kind of anesthetic possible to really help with the process.
is there a lot of postoperative pain? Because I'm a baby, Dr. Lamb. I'm a baby.
So I tell patients that you can just use acetaminophen if it's a really large lesion and I anticipate that it's going to be quite tender afterwards. So usually those are patients that are either uncontrolled or poorly controlled still while on a biologic or just a really, really large area. I do give them T3 prescriptions for a week.
Okay.
Yeah, and that
So
usually tends to take care of it for
you
them.
mentioned you can be doing this for an abscess when they're flared, and
Yes,
many
yeah.
times these are very inflamed, and
Yes.
inflamed skin is often very difficult to anesthetize.
Yes.
And I'm imagining that deroofing a very inflamed abscess-like lesion is going to be a lot more comfortable than a quieter lesion, correct?
Actually, you'd be surprised. So the goal of wanting to put you on a biologic first is to get quiescence as much as possible and to shrink the size of the surface area that we need to remove. So my nurse Danielle Wilgus, she is amazing. She's the way that she freezes the really active lesions is that she essentially does like a block, a ring block around the area. Don't be silly like me. And I went for the gusto the first time right into the lesion. I think because you're used to doing that for, lesional removals. So make sure you freeze from further away, and then you don't necessarily have to inject into the lesion.
Right. That makes a lot of sense. Anything else? I'm sure some reassurance, letting them know there's a problem, they can call your team, your office is
Of
accessible.
course.
There's always a dermatologist on call, etc. Correct?
I think if a patient's a little bit hesitant and I can tell that they're going to really benefit from deroofing, I tell them, hey, guess what? This is no different than the daily dressings that you're already doing for the lesion that keeps draining and won't go
Yes.
away. It's seriously.
Right.
But at least if you're going to go through deroofing, then you know that it's finally going to go away and you're going to finally get some pain relief. I have patients that tell me in the room, as I'm not even done yet, and they tell me I'm getting pain relief from the
Well,
deroofing. So
with the deroofing, you're also releasing a lot of the pressure, right? That
exactly.
which has a lot to do with the pain. Like what you said in the first video, incision and drainage. A lot of times is just to remove the pain. It's not necessarily to get rid of the entire lesion, right?
Exactly.
Okay. So what about the technique itself? How could someone learn how to do deroofing? I would imagine there's good videos. It sounds like you could learn a lot by doing it that way, but do they have to go watch someone and get that kind of experience? I know you do a lot of teaching in your office with
Yeah.
this.
Yes. So I think for simple lesions, you probably could watch some videos and learn. So I've included one video of a simple lesion and then a video of a very difficult large lesion and how I would approach those for deroofing. But I would really highly recommend doing a preceptorship. Um, at least in Canada, you can reach out to the industry partners that you have, and they can help sponsor you to do a full day preceptorship, which is what I do with the dermatologists that fly across the country to come do it with us. So, because there's
So
just so
do
much
you accept
variance,
Americans coming up there?
I would be open to it as long as, red tape and politics don't get in the
Yeah,
way.
you never know. You
I
never know,
know.
right? Right? Background checks and all
I
that kind of
know.
stuff, right? So what
Exactly.
about with different types of using a scalpel versus a scissor or curved scissor? It depend on the type of lesion, how you're going to match up what some of the surgical instruments are.
Absolutely. So if you know you're working in an area that has very thin skin, so the axilla, the breast, even the inguinal area or the mons areas, I tend to like to use the curved scissors better. So what you're basically doing is you're using the curved scissors and you're trying to probe. You're trying to see where the sinus tract goes, and you're basically following along the sinus tract, and then you're removing the top or the roof, which is why they call it deroofing, and then leaving it for secondary intention.
Right.
The way it differs from, for example, excision, the way that plastic or general surgeon would do, is that you're trying to leave the dermis intact. That way, the patient has faster healing, and the you are able to track where the sinus tract goes, as opposed to just blindly circling a whole area and then just excising, right? So they've actually looked at studies, and deroofing is about 90% successful, depending on the surgeon themselves, versus about 70% for excision. So,
Yeah.
yep.
So we already talked about the postoperative wound care. Infections
Yes.
rare. The wound care is pretty straightforward, but you obviously educate them on it. Your staff does that. Um, and what about follow-up? Do you do any kind of texting or emailing with patients to just to see how they're doing before they come back for their when do you see them back
Right.
in the office? Right?
So when I first started, I would get patients to come back in 2 weeks, just because biofilm tends to develop around that time, and patients think they have an infection, right? So if you're first starting out, that's the time frame that I would do. You can keep following them every 2-3 weeks or so if you want to see the progression, and I would suggest that you familiarize yourself with that. But because I do so many, and we have such a high volume, what I do is I ask the patients to email us if they're having concerns, and we respond right away. But that way, at least you're able to assess with a photo and to give some management suggestions that can be remotely done as opposed to having to get every single patient in.
Right. And so you had mentioned that you do a lot of these procedures on Fridays.
Yes.
That gives people time to recover, less time off of
Exactly.
work, right?
Exactly.
You're rarely going to have immediate complications where you can't go to your Calgary Flames hockey game in your glass seats because you have to go see a patient that had a problem because you did not de-roof properly, young lady. Okay, so I mean that doesn't sound like that's not a big issue that comes up. You book.
Rarely you can get brisk bleeding. I find that happens 24 hours afterwards, and I think what might be happening is that the epinephrine is wearing off, and you may have had a vessel that just, because these are frictional areas, may have gotten disturbed. That's really the only very rare complication that might be immediate.
And you book around 45 minutes, but then people.
I book about half an hour now,
Yeah, probably because you're faster than
Yeah,
you were
exactly.
when you first started. But the
Exactly.
video, it sounds like, let's say you have somebody that's calling in and they're having trouble getting in, and say, okay, we'll fit you in today. Just realize that we have other people here. We'll get you in. But the fact that you have the video makes it a lot easier than having to do all of it. Though you're not going to shortchange people and shove
No.
them in and say, you saw the video, we'll schedule you and see you in a week or whatever.
Exactly.
They're going to be treated with respect and time. But the video cuts down on the amount of time if you're adding them on to your already
Absolutely.
busy schedule. Okay.
Exactly.
That sounds like it makes sense. Now, what about consent,
Right.
cancellation, people that are poor responders? Let's go through some of the scenarios, because not everything's going to run perfectly, even in your hands doing so many, correct?
Absolutely. So with consent, I always mention the most common complications people can get. So I mentioned biofilm, but actually the other most common is hypergranulation tissue. So that often happens probably around 3 or 4 weeks after the deroofing. And interestingly, you can actually manage it topically with clobetasol. It works really well. So,
Well, interesting. Right? What about people that don't show up? I mean, you're booking a half hour. That's a lot of time in an office.
yes.
And they don't show up. So do you have a policy they sign up front that if they don't cancel within an X amount of time, they're going to be charged a fee?
I think you need to know if you're going to be working with HS patients is that they tend to be they're a bit less committal to things. But I do tell them that we charge a cancellation fee or no-show fee if they do that before 48 hours. I do have a very long wait list now. It's probably out till May or June now. So
You can get people in on short notice if you call.
exactly. But we also use a text reminder, and in the text reminder, it also links back to the video so that, again, they can refer back to the video if you need. I've found lots of these things very helpful because deroofing is such a foreign concept. It's foreign to dermatologists even. So to expect the patient to know after one 10-minute video that they are going to have no questions whatsoever, probably difficult to live up to.
So I'm ready. De-roof me. Right? De-roof me. I put on my anesthetic for 3 days,
Oh boy.
many times a day. So I'm very numb and ready. Lauren, do you have any final comments about the hidradenitis suppurativa, the management of the patients? Obviously, it's very rewarding when people get better with the better therapies we have, especially these biologics, in combination with helping them with other problems like weight loss, and smoking is a big deal. But, being compassionate, it's not that easy to lose weight, and it's not that easy to stop smoking for many people, right? And,
Absolutely.
but also the surgical side of it, which I think a lot of dermatologists maybe are not as familiar with, the level of satisfaction you see from that, I imagine over time is why you're still doing it. Right?
Yes. So I think I just want to leave the audience with this thought. Medical and surgical management combined is the gold standard for HS treatment. And I have seen patients that have been on updosed biologics that still are not clear, that are so miserable. And by being able to do deroofing for them, you've given their life back. So I would highly encourage you to learn a little bit more about deroofing, see if that's a practical thing that you could include in your practice, and give it a try, because really you can change someone's life. Even a small little lesion that's been bothering them for many, many years, you'll have the happiest, most grateful patients. And that's what we're doing this for, right?
Yes. What I'm hearing from you is the patient could be on a biologic, and so many of these other areas are now quiescent and not even
Yes.
happening.
Yes.
But that doesn't take away the fact that this one or two areas are making them miserable. So they're still
Yes.
miserable, even though they're much better from their medical treatment.
Exactly.
Right?
You can actually make a patient clear and keep them clear with deroofing. So
I'll reference my wife. If my wife has one pimple, the world is coming to an end. And if she had 40, right, the world would be coming to an end. So that one is just as bad as the 40 in her mind.
I
Right?
can relate.
And yeah, I could, I think that's true. It sounds ridiculous, but it's
Yeah.
not. And
Yeah.
so that one area that's problematic of those two areas is overshadowing how much those other therapies have helped really get their disease under control. And if you ask them, they'll say yes, but they're like, I can't stand this. You got to get rid of this problem. So that makes tremendous sense to me. Right.
Exactly.
Thank you so much. Okay.
Thank you so much.
I appreciate it. And
I hope
thank
the
you.
tea was.
Yep. Well, I owe you a cup of tea because we didn't get you your teacup in time.
Maybe the next
right?
one I'll have a teacup.
That's
too.
right. You'll get a teacup. Lauren, thank you so much. You have a great rest of your day. And I know our viewers, not listeners only, but
Yes.
viewers, are going to really appreciate the discussion and the graphics and videos that you provided for this. Thanks a lot.
Thank you so much, Dr. Del Rosso.